Hi everyone, my name's Casey. I'm going to be doing my respiratory assessment on my client here. We have all of our full PPE on, our scene is safe, so we're ready to enter and start with our assessment. So we're entering the scene. We're going to check if our patient is responsive just by introducing ourselves. So, hi, my name's Casey. I'm from the ambulance service. How are you going today? While she's responding, we're noticing if she is talking in full sentences and if she's alert for our airways. While she's doing that, I'm also going to be doing a general impression, just looking around her environment, seeing if I can see any oxygen tanks or masks or asthma puffers, seeing if I can see any smoke butts or anything that could contribute to a sort of a respiratory distress for a client. So once I've done that and I can assess her airways the way she's talking back to me, we're going to be doing our breathing. So while I'm going to be checking her breathing, I'm going to get my colleague who will be checking how many rest rates she's going to be doing while we're doing that per minute. So we're just going to check on your breathing. Is that going to be okay? So while I'm checking her breathing, I'm looking to see if she's using any accessory muscles, if she's having any difficulties in breathing normally, like the nose flares, anything in particular that I can notice. And while I'm going to do that, I'm going to be doing some oscillating just to check if I can hear anything. So just going to oscillate 4 times really quickly, the front and the back. Now, do you mind if I check it on your back as well? Beautiful. So her airways, I've just checked that through my stethoscope, and my partner's also done a respiratory rate. Now we're doing our C for circulation, so I'm going to be checking her hands, seeing if we can do a cap refill, seeing what the cap refill is, checking the temperature as well while I'm doing that. And then after we've done that, we've done our primary survey, So now we're going to be doing a critical intervention. So there's no critical interventions because it's not a trauma situation. She's just suffering some respiratory distress. So now we're doing some vitals, which my partner's going to be doing. While my partner does vitals, I'm going to be doing my history taking, my sample and OPQRST. So we're going to ask the patient questions in regards to how this happened, why it's happened, if it's happened before, the quality of pain, where the pain is, and all those types of questions. So once we've done that, then we move on to our focused assessment, which is our respiratory assessment. So we're going to inspect the client. So I'm going to ask her to remove her clothes, or so I can actually see what's going on her chest. So while she removes the clothes, I'm looking for any signs that she's had any surgeries, any scars, any rashes, any colour differentiation. I'm also looking for cyanosis around the lips. So I can also check in the eyes where she's got any oxygen, low oxygen levels. So now that we've inspected the client, we've looked from the front and the back, nothing seems to be too abnormal. So then we're going to move on to our palpate. So when we palpate, we're going to be checking for any crackling, any emphysema, any tenderness, and checking for the expansion. So we just palpate across the chest. Can we see that yet? We do the same at the back as well, palpate across the back. We're going to ask her to take a deep breath in and a deep breath out. Seeing if that hurts the client anyway, and making sure that she's getting equal air entry. By holding that, I can tell whether she's getting equal air entry into her lungs. After we've done that, we're actually going to percuss and see if we can hear any dull sounds or any abnormal noises. So we do this in between the intercostal spaces. Then we also do that at the back as well. Beautiful. So now that we've percussed, we've done our IPP, now we're up to A for oscillate. So we're going to oscillate the chest again, but we're going to do each of the lobes. We're going to do 3 at the front. So the right side we know has 3 lobes, the left side has 2. We're going to do it at the back as well, just to see if we can hear any crackling, any wheezing, any sort of sounds that might be making her have these weird chest feelings and all those types of things. So we go in the second intercostal space for the top of the lobe, up near the collarbone. We're going to ask her to take normal breaths so we can hear what's going on in through her mouth and out through her mouth, but not too loudly that I can't hear through my stethoscope. We know the fourth intercostal space, so we feel down, second, third rib, third intercostal space, fourth rib, fourth intercostal space. And doing the same for the sixth, which is down the lower part for the lower lobe for the lungs. And then we do the exact same at the back. Beautiful, and based off what we can hear, we can definitely tell whether our patient is suffering any sort of COPD, any sort of asthma attacks, any sort of thing that's going on with her lungs there. Based on her history, taking her vitals, and on the sounds that we heard through her chest is what we're going to do, whether we're going to take her to hospital or not. And that's my respiratory assessment. Thank you.